But before we do, I want to point out that we are recording the meeting, as you just heard. The meeting recording will be available about 2 to 3 days after this session today. If there are breaks in the internet coverage, we'll do the best we can. We've had some spotty internet coverage today. Is as typical as the fluctuations in temperature in the room. So with that, I welcome everyone. I'll turn it over to Dr. Delbridge to run through a introduction, but I really call it an issues assessment as well. Dr. Delbridge.
Thanks. Thanks everybody for being here and for being online. We wanted to start off with an opportunity for each of the committee members to offer their perspectives on sort of what brings them here, what lens they see the issue through, and what they see as opportunities and challenges to improve, optimize funding for the trauma system in Maryland. I'll give it a go just to start off. So again, I'm Ed Delbridge. I'm an emergency physician. Prior to coming to Maryland almost 4.5 years ago, I was an emergency physician in trauma centers in Pittsburgh and Greenville, North Carolina, both fairly busy places that are like comprehensive level 1 places. So I have some perspective on being on the inside of the trauma center.
Thank you, Brian.
For in my current role, my principal interest is in making sure that we optimize the system of care that we provide Maryland patients. I think we'll hear over the course of our deliberations and our and just the input that we got that Maryland's trauma system has long been thought of as a model for trauma systems throughout the United States. It functions because of the interconnectedness of the various trauma centers in the state and the reliance on community hospitals and the EMS system on those centers. And so first and foremost in my mind is that we preserve or optimize those relationships and make sure that whatever this is all about funding. So whatever funding stream that we imagine for the system maintains that systemness, if I could use that term. I know that every individual trauma center has its particular priorities, challenges and opportunities. And I hope that we work through those in a manner that maintains that interconnectivity, that preserve what it is that it's so highly thought of in terms of Maryland trauma centers. It really does set it apart from other states in the United States. That's my spiel.
I'm Andy Pollack. I serve as the Chief Clinical Officer to the University of Maryland Medical System. In that capacity, I have responsibility for clinical care at two of the, I think the 2 largest trauma centers in the state, at the Adams-Cali Shock Trauma Center and at Capital Region, Capital Region. My background, I've been a practicing orthopedic trauma surgeon. I was just thinking about this as I was driving up here, entering a week into my 30th year of that at Shock Trauma.
So kind of new at it.
Kind of new at that part, yeah. No, I'm kind of new at the administrative stuff, but I've been doing on the clinical end of it for quite a while. In that role, I served as Chief Orthopedic Trauma at Shock Trauma. I served as Chair of the Department of Orthopedics, and in that context, I ran a faculty practice plan that was heavily dependent on trauma care or heavily involved in trauma care. So I faced the challenges of a physician practice plan in managing the financial challenges of delivering trauma care in the state of Maryland, and which are similar to those challenges everywhere in the country. I also have had an opportunity for 21 years to serve as the medical director of the Baltimore County Fire Department. So I had a lens on the delivery, the trauma care delivery challenges from the perspective of our EMS providers, and the need to be able to access those services, not by waiting, but immediately, and the importance of the standby function that those trauma centers play and being immediately ready all the time and never saying no. in my current role, I had one other role over time. I chaired the Maryland Healthcare Commission here for a period of time. So I think that gives me a broad perspective on these challenges. I think when we look at this currently from both the hospital and the physician practice perspectives right now, we're looking at it hopefully on the tail end, but maybe closer to the middle end of a massive increase in the cost of labor across the board. And that's not just the cost of nursing labor or tech labor in the hospitals, but physician costs are going up. We have to be competitive with the region, not just the state, and really the country, not just the state, in terms of being able to attract physicians. Those costs layer into not just the practice plans, but the hospitals as well. The ability of the hospitals to absorb that additional cost is not increasing. In fact, it's dramatically decreasing. We know that over half of the hospitals in the state of Maryland last year ran negative margins. That's not a sustainable model long term. And what suffers in that situation is the ability to run entities that may not be viewed as productive on a day-to-day basis as they could be. So the standby cost associated with keeping things open is not something that you can help to sustain. There's always been help through the system for standby costs, but it's always been just help, not complete offset. And when that happens, we have problems with labor staffing. It creates an access to care problem. Ultimately, looking at it through the lens of access to care, I think is very important. But additional funding is desperately necessary to allow the hospitals and the practice plans to continue to deliver care the way we have.
Thanks.
Trudy. My name is Dr. Trudy Hall. I am a physiatrist, a physical medicine rehabilitation physician. I have a couple of lenses. My first lens is always going to be as a physician. I came in 1995. I'm almost the same number of you, Andy, to Baltimore to start my private practice. So I was in private practice in multiple areas for many years. My second lens is as a physician executive. I was with the University Specialty Hospital as their medical director and chief medical officer for the coma and behavioral health injury unit. So I saw mostly the patients that came from shock trauma, and as a state, we do an amazing job at saving lives, but the rehab and getting those patients back to the community is also the continued investment that we have to make to give those patients care. And then for 10 years, I have been with the Prince George's healthcare system, now UMCAP as a physician executive. And in that role, really saw the challenges of the unique challenges of the level 2 in dealing with the ability to maintain and sustain and subsidize physicians to provide that care. My current role for the last year, I've been with Tidal Health, which is the healthcare system, trauma healthcare system for the Eastern Shore of Maryland. There we face unique challenges. The next lens is really as former commissioner of the HSCRC. We have a unique opportunity to look and see where our costs are and really at our payer system, where do we need to be able to level the playing field to continue to provide this care. And then my next lens is really my leadership in the National Medical Association for 20 years, being the state president, now regional chair. In that role, really looking at healthcare disparities, health equity, and access to care to our most vulnerable population, and make sure, again, that there is a level playing field and care that we provide. And then lastly, as a resident, myself, my family, friends, they're counting on us to figure this out. We have to figure out how we're going to modernize our payment system to be able to continue to meet the challenges. So, but for Tidal Health, again, it's the Eastern Shore healthcare system. We receive 300,000 visitors per week, almost 8 million per year, and it comes from every single county in Maryland. So it's not just the Eastern Shore problem, it is a Maryland state problem that we make sure we maintain that healthcare system. We're a 283 bed hospital. And for us, that golden hour to meet those needs for those vacationers in Ocean City, we have 2 college towns, universities that are in our backyard. A lot of stuff happens. It's a 2.5-hour drive to the nearest trauma center if we were not there on the Eastern Shore. And that's on a good day without traffic. And then sometimes we can't even fly because of weather conditions to be able to get a patient. And even currently, even when we stabilize a patient, it could be 8 to 9 hours before we can get that patient up to Baltimore into our tertiary care system. So, the bottom line is we need to figure it out. I'm going to echo what Andy just said. Our costs are increasing. A lot of focus has been on nursing costs, but physicians now have reverted to locums. We actually have companies like anesthesia shortages and urology shortages. We have ENT shortages. We have shortages in many areas of specialties and subspecialties that is needed to provide trauma care. And then really our state, and again, our MIM system acts as a level 3 to have 12 additional subspecialties to be on call and to be standby to be able to provide that care, which we're proud that we do. So the opportunity we have, we're sitting here today. I think we have a unique payer system. We have legislative support for us to really look and see how we modernize our system. And on Monday, Billy, a 4-year-old kid, came back with his parents to say thank you for saving his life. So if not for ourselves or our family, Billy and his parents are expecting for us to figure this out. So thank you.
Thanks.
Hi, everyone. I'm Allie Carter. I'm not a doctor. I am the Chief of Staff to Senator Elfreth, who is on the line, and she will take the intro from here.
Go ahead, Senator.
Thank you, Allie, and thank you, everyone. I apologize for not being there today. I'm on 3 work groups this interim. I was in Baltimore yesterday for one, so Allie and I will always tag team, 1 person in the room, 1 person on Zoom. Grateful for the opportunity to hear everybody's perspectives. I'm Sarah Elfreth. I've been in the State Senate for 5 years. I represent Anne Arundel County, serve on the Budget and Taxation Committee, and as chair of the subcommittee on Public Safety, Transportation, and Environment. My lens here is really going to be that of an appropriator. The funding crisis we're facing in this room is similar to other crises we're facing throughout the state's budget. I know I see DBM Secretary Grady on the line. She knows this very well. So my role here is really to listen, learn, communicate the Budget and Taxation Committee and the Senate's viewpoints to the room, and then your viewpoints back to the committees, and make sure that we find a long-term solution to funding this critical care. Thank you.
Thanks, Senator.
Good afternoon, everyone. My name is Kate Cooksey. I'm the Deputy Director of Rate Setting at the Health Services Cost Review Commission. My lens is a little bit unique compared to everyone else's so far. My team is tasked with creating the global budget revenues and the unit rates that are under those global budgets for all of the acute care hospitals and some specialty hospitals in the state of Maryland. I am coming here from the lens of a regulator. We have a regulatory statute that rates need to be reasonable to cost. And so to the extent that trauma funding is included in the cost structure of the hospital and they report that to us, it will be included in the overall global budget revenue and rate structure at the hospital, but we do not have a separate trauma adjustment that we put into rates. I think the overall assessment and challenges in the state of Maryland is what Mr. Pollack spoke to earlier, and that the staffing and agency costs have skyrocketed over the last several years, mostly due to the pandemic. So we hear a lot about that when we have our discussions with the hospitals. And I think there's also a lot of opportunity because of our unique system, and I look forward to being part of the discussion.
Thanks, Kate.
So we have our MHCC staff here. Everyone knows Tracy DeShields and Luanda, but we're going to jump over them in terms of going to the next commission member, which I think is.
Yeah, I'm Pat Gaynor from MIMS Government Affairs. I'm also here as staff. Happy to see everybody.
I'm Elizabeth Wooster. I'm here as the Director of Trauma for and Injury Specialty Programs for the state for MIMS. What have I done in the past? I am a registered nurse, and I have been a nurse for a pretty long time. I've worked frontline medicine, trauma, critical care, and adult and pediatric for a long time, as well as field medicine. So I've done a lot of different hats, but always in the beginning, in the front line of medicine. What I care about, what I'm here to kind of put forth here is, one, I believe that this fund represents a service. And I believe that it is our job and as a state to work just as that, as a state system, which has many parts that add up to the whole. And that each part is dependent upon the next part. And I think it's important that we keep that in mind, and that to serve our patients and our citizens is our greatest honor and charge with this.
Good afternoon, everyone. My name is Christian Kane, Dr. Christian Kane. I am a trauma surgeon. And let's see, through what lens am I bringing a perspective here? I would say I'd echo Dr. Hall's first acknowledgement of being a physician and a surgeon. I came to the state of Maryland in 2017 with the intent purpose of making me a stronger surgeon. Maryland has done that for me, and in exchange, I've given my professional interest back to the state of Maryland through my work at the University of Maryland, shock trauma now at the Capital Region Medical Center, which is in Largo. There, I bring in my second perspective, which is as a physician leader. I'm the interim trauma medical director of the program, and have overall the assessment that I would make about the current state that we're in is sort of informed through the experience that I've had throughout my professional experience, as well as my training experience. So I've had the privilege of seeing systems in Chicago, Illinois, in New York City, in Connecticut, and now here in Maryland. And I will echo Dr. Delbridge's his overall assessment of the fact that the eyes of the nation, the eyes of the world are on Maryland. The standard of trauma care are derived from the work that we get done here, and also the ways that we take care of people and the priorities that we set are also being looked at as well. So I'm happy to lend my voice and my experience to this process, and look forward to working with you all throughout the year.
Thanks.
I'm Mark Marcantano. I'm the Chief Administrative Officer for Pediatrics at the Johns Hopkins Children's Center at Johns Hopkins Hospital. Been here about 4 years, so I'm a relative. Prior to that, I would say about 21 plus years experience through senior executive positions, Albany Medical Center, Boston Children's, Women and Infants Hospital in Providence, and now the privilege of being at Hopkins. So clearly my perspective will be pediatric trauma and burn. I think we share a lot of the same stressors, challenges, gaps, and I'll say opportunities that many of the stakeholders will share around the table. You will hear us keenly interested in not only shoring up our current state, but interested in any bandwidth we have to be aspirational. I think we all roll with a continuous improvement mindset. So we'll be looking for those opportunities as well. I would also maybe mention that a high priority for us is non-accidental trauma, child abuse, child protection team. I think that responsibility is a privilege of helping the children of our state in that area, and we're hoping there's some opportunity to discuss that as well in the deliberations. So here I am, which to serve.
Good afternoon, everyone. First, I want to thank the state of Maryland and the Health Commission for affording me the opportunity to sit on this forum. My name is Katina Williams. I am the Vice President of Finance and the Chief Financial Officer for the Johns Hopkins Hospital. More of a newbie than Mark. I've been at Hopkins for 2 years, also been in the state of Maryland for only 2 years. Prior to that, I was the CFO for network expansion for the Duke University Health System. I was there for 21 years before coming here. So I'm relatively new again to the state. So I share the lens of financial officer, but also the lens of my colleagues, which I've had the opportunity to speak with regarding the trauma fund here. And there are a couple of things that I want to point out, one of which Dr. Pollock so eloquently laid out is really related to some of the financial stressors that we have experienced in our institution related to ongoing operational costs due to premium labor, also inflation on our supplies, as well as some of our infrastructure costs. And so those are realities that many of the hospitals and institutions are facing. And so while we recognize that this trauma fund is an additional source of revenue for us, we are concerned about the usability of the fund, and particularly according to many of our physician colleagues, the burden that is placed in order to be able to apply and receive reimbursement from the fund. And so there is some concern that that process could be a little bit more transparent and easier. The other thing that we're concerned about is really looking at the cap for on-call reimbursement and the compensation equivalent. It's too low and often leaves a significant unfunded gap for many of our organizations. And so while many trauma centers are exceeding the allowable threshold under the current statute, this may now be prime opportunity for us to review those thresholds and see if there's some additional funding that can be allowed through that. We also want to look at the expanding of disciplines that are represented that are eligible for reimbursement. Many of us incur non-clinical personnel costs and administrative costs to be able to run our trauma programs, and would like some recognition given for the offset of those costs. And so again, very grateful to have the opportunity to sit on this committee and looking forward to some really good work that we can do through this. Thanks.
So good afternoon, everyone. My name is Ray Pang. I am a practicing active trauma surgeon and have been so for not quite as long as Dr. Pollock, only over 20 years. I don't know the exact number of when it started. And I've been a trauma surgeon in the state of Maryland for 12 years. My first 6 years in Maryland, I was at shock trauma. I was there in the service of the U.S. Air Force. And then I retired and moved over to Bayview to become the trauma medical director. I'm also the current chair of Maryland TraumaNet, which is the organization of trauma centers within the state of Maryland. I'm the chair of the Maryland ACS Committee on Trauma, which is our own surgical professional group's kind of trauma advocacy group. And I am a American College of Surgeons Trauma Center reviewer. So I have a pretty broad experience going all over our country and seeing how trauma is supported and practiced from level 1, 2, and 3s. And actually, there are many more level 3s in our country. So many of the centers I visited have been level 3s. As I mentioned, I was a previous Air Force. In my 22 years of the Air Force, I helped build the military trauma system serving Iraq and Afghanistan. So I also saw how we put resources in every nook and cranny to give our wounded warriors the best chance of survival. And I understand the logistics and issues with putting advanced care in remote places. And so that's kind of my background. I will also say that you can either give me credit or blame, but I am one of the people that really promoted the creation of this commission because I think it's a very important thing. And I think if we don't do the right job with this opportunity we have, it won't come again for quite some time. In terms of what lens, I am a frontline provider. I still take a lot of call. I take care of a lot of patients. And I see the things that we do very well. And I see the things that we don't have as much support as perhaps I see in other states. And I am a fan of the Maryland trauma system. I talk about it all the time, and I think it's fantastic. And I think we need to stay at the top of our country in trauma care. My assessment is we have a fantastic system already. It could be better. It is strained financially. We have diverse centers that are in very different practice settings. And so that makes it very challenging. And I have to say the medical reimbursement system in Maryland is also challenging for trauma care compared to some other states' funding. I think it has everything in the world has pluses and minuses, and everything has challenges. And I think we just need to work through all that to do the best we can, take care of our patients, and keep our system as great as it is.
Thanks. I think David Coombs, I think I have that right, is on the line for Delegate Shetty.
David Coombs is her chief of staff.
Yeah,
Does you want to say anything?
Yeah, I'm sorry. I'm just here on behalf of Delegate Chetty, who is out of town and looking forward to participating. Thank you.
She's somewhere fun. Dr. Herrera Scott?
Hi, Laura Herrera Scott, Secretary of Health.
Bonnie DiPietro, are you on the phone? Not on. Bonnie is the Vice President of the Maryland Patient Safety Center. I guess we'll catch up with her. And James Gannon, I think you're on.
Hi, good afternoon. My name's James Gannon. First off, thank you all very much for having me here. I'm currently here on a couple of different lenses, I guess. I'm the former chair of the Maryland Trauma Center Network, TraumaNet, just as Dr. Fang was just talking about, and also probably one of the bigger advocates for us to have the fund taken for review over my 2 years as TraumaNet chairman. I think in just about every one of our meetings, I was mentioning or discussing with somebody as to when we can do this. Unfortunately, we had that little pandemic that held things up, but I'm very excited that we're here now. I also wear the lens of the trauma program manager at Sinai Hospital, Level 2 Trauma Center here in Baltimore. Over the course of, I've been a registered nurse for about 15 years or so. And before travel nursing was really cool, I actually did travel nursing, working at Level 1 trauma centers across the country, from University of Arizona to Ben Taub, Colorado Children's, so just to name a few. So again, I'm very excited that this has finally come to fruition. I think there's a lot of opportunities within the fund and within our trauma network across the state. You know, when you look at this, I think the fund was initially created back in 2003. And since then, it hasn't really been a good lens hasn't been taken to this since then, or any changes. And if you look at COMAR over that same period of time, Trauma COMAR has changed a couple of times. Some of those changes are to increase the need for specialty surgical and non-surgical services, which has really, I think, is one of the bigger things that has increased expenses of running of a trauma center, outside of all the other costs that have previously been mentioned. So again, I look forward to it, and thank you very much for having me.
Thanks, James. And Secretary Grady, I think you're on the line. Do you want to say hi?
Sure. My name's Helene. Can you hear me?
Yeah.
Sure. My name is Helene Grady. I'm Secretary of Budget and Management for State of Maryland, and am eager and excited to be part of this commission. The lens through which I'm coming is through the state budget and the challenges of ensuring that our funding model here in Maryland supports at an appropriate level the vision that we all have to continue and maintain and enhance this nationally and globally recognized trauma system that we operate here in Maryland. I'm really eager to learn. I think similar to Senator Elfreth, I don't have a lot of experience or knowledge to bring, but very excited to learn more about how we do this today and how we can optimize going forward.
Thanks. So I hope by going around the room a little bit, everybody gets the sense that we have a very diverse and interested group that will bring a lot of different perspectives to the issues and be able to identify challenges and creatively find opportunities to make a difference. Thanks everybody for being here. I'll turn it over to Ben. Well, I'm sure we'll get his story and carry on.
Very good. Thank you, Dr. Delbridge. So very interesting to hear everyone's perspective. And I think the word everyone used is nationally respected, well-known, best in the country. So I have a story about that because the Healthcare Commission has been the custodian of the fund since 2003. And at that point, MIMS and MHCC worked together to establish the legislation. I thought I was doing a bit of good research, and I identified a trauma physician, Paul Tahiri, who at that point, I believe, was at the University of Michigan, but had done quite a bit of work on the cost of operating a trauma center. And I posed that to Dr. Bass, who was unimpressed. He said, we really don't need to reach out to other states if we want to think about who's doing good things in trauma care. So I learned my lesson early, and it's been repeated today that we all are extremely proud of the trauma system that's developed here in Maryland. And it actually, there was one article I did circulate to you, which talked about funding in other states, and it's pretty minimal. What's done in Maryland is another unique aspect of our system here. Important though, we are the custodian. The trauma fund, as originally conceived, was supplemental, not a core part of funding for trauma. And increasingly, I'm hearing that supplemental aspect of trauma funding starting out in 2003 has grown, and there have been some statutory changes, pretty limited though, but the needs are growing. And I think it's true to say that Dr. Fang recognized that a reflection on what the trauma center funds and what it does not fund is an important initiative. But as you'll see momentarily, the charge is broader, and it is possible that this commission may come up with recommendations beyond expanding the trauma fund. That I would encourage everyone to leave themselves open to those ideas as we start this important work. What I would also say is that the fund does have some imbalances that I think can be pretty easily corrected. But there are going to be, they're going to require statutory changes that we could make better use of the funds that are collected, even as we focus on a broader range of perhaps expansions. So welcome everyone, and I think we can jump to the next slide, which is turning over to Dr. Delbridge again, talking about the highly respected Maryland trauma system. A word about it.
So we thought, since we had such a diverse group assembled, that we might spend just a few minutes kind of establishing some groundwork, getting at the lay of the land. And I would just point out, so these are Maryland's trauma centers. Depends on how you count them. Not included on this list is the Hand Specialty Center at MedStar Union Memorial. Not on this particular list is the Children's National Hospital, which we count as part of the pediatric trauma system, and the Wilmer Eye Institute at Johns Hopkins. But these are generally them. In calendar year 2022, if you count Children's National Hospital, the Maryland Trauma System cared for just over 25,000 patients. So when we talk about making a difference for Marylanders, it's for 25,000 people who use the trauma system every year. And next slide, please. And that's been pretty steady. These are where the trauma centers are in the state. You can see there's the primary adult resource center, the R.M. Skelly Shock Trauma Center, is statutorily designated from law in the early 1990s. There's one level 1 trauma center at Johns Hopkins, 4 level 2 centers, and 3 level 3 centers, and as I mentioned, 2 pediatric centers. And as you can see, they're very well distributed throughout the state. And Dr. Hall made this, the observation. Tidal Health is like way out there, and without a Tidal Health Peninsula Regional would leave part of the state barren in terms of trauma care. Same is true in the western part of the state, in Cumberland and Hagerstown. So we by just good luck or hard work or some combination of the two have developed a very distributed system for trauma care throughout Maryland. Next slide, please. This is where the patients end up. Each slice in the pie is a different trauma center. The narrowest slice of the pie is the Pediatric Trauma Center at Johns Hopkins, which thankfully is the narrowest slice of the pie, right? I mean, that represents children. But as you can see, every place else does its fair share of trauma work. So there isn't like a part of the system that is not functioning in terms of caring for people in Maryland. Every component is incredibly important. So when we talk about the systems of care, this is part of that equation or that observation. It's important. Next slide. This is a depiction of the proportion of patients or the number of patients cared for at the various level trauma centers over the course of time. The green bar is 2005 and 6, and then the other bars are more current. The magenta bar is from calendar year 2022, or the most recent experience. And you can see the vast majority of patients are cared for at the level 2, not the vast majority, but a big chunk of patients are cared for at the level 2 and level 3 hospitals in the state of Maryland. And this fluctuates a little bit over time. Some of it is just biologic variation. Some of it is flow of patients to particular trauma centers based on the interests of those trauma centers and their relationships with the EMS system. And some of it's a little bit administrative and how things are counted, quite frankly. But again, you get the idea that every component of the trauma system is incredibly important. And there isn't one we could say, for example, lop off and say, don't need that. That just isn't the case. It isn't our reality. Next slide, please. We're going to talk in a second about judging severity of patients. So just a little quick groundwork on how that is done. And the trauma surgeons, don't pick on me for being too overly simplistic. But retrospectively, we discuss often the severity of injury based on a score called the injury severity score, which is made up of an abbreviated injury scale that divides people's injuries into 9 different body regions, categorizes them as minor to extreme. And so each injured region is categorized from a 1 to a 6. That's the abbreviated injury scale. Injury severity scale, which is sort of the aggregate of that information and has more clinical utility than the abbreviated injury score does, takes the top 3 abbreviated injury scores, squares them and adds them. So if you had an injury to your head, your chest, and your abdomen, and those were the worst, you take the scores, the 1 to 6, square them and you add them up. And that gives you an abbreviated, an injury severity score, an ISS score. A score less than 3 means you're not too badly hurt. A score more than 15 conventionally means you're seriously badly hurt. And it's arithmetically impossible to have a score of 15, which is why that's the cutoff. So both of these things have flaws. They're not perfect, but they're sometimes a good way just to convey the overall dimension of injury severity in an aggregate. Any questions before I move on? Anybody want to quiz me on that? Anything you want to add, Dr. Peng, Dr. Pollack, Dr. Peng? Okay, I must have done a great job. Okay. I didn't make it too complicated, not too simple. Well, we see a lot of minor injuries in trauma centers. That's going to come up over the course of time. So I just thought I'd just toss that out now. It turns out about half the people we see who end up in a trauma center end up having minor injuries. The challenge is that that's through retrospective evaluation. That's after they got an emergency head CT scan and abdominal CT scan and their orthopedic injuries were assessed. And so it's important to know again that every trauma center in the state sees its share of minor or not hurt people. Sometimes not hurt people end up at trauma centers. Best case example I can give is somebody that has intracerebral bleeding that, in the moment in the field, in the EMS system might be thought to be due to trauma, but retrospectively, which is how all these scores are derived, it turns out their bleeding was due to a hemorrhagic stroke and what didn't relate to trauma at all. So they don't get an injury, they don't get a high injury severity score because it's not trauma in the way that we think of trauma. They needed to be at a tertiary, high-speed, intensely neurosurgical place. So every trauma center sees its share. So again, I'm trying to make the point, can't lop off a part and say, they see all the non-hurt people, we didn't really need them, that didn't need to be a trauma center. there's opportunity for every trauma center to see not her people, and every trauma center in Maryland sees its share of those people who retrospectively weren't as hurt as they were feared to be in the field. It's also important to note that through no special work that's done in Maryland, or maybe because of the systemness that we enjoy, we have conditioned non-trauma center hospitals to defer evaluation of potentially traumatically injured people to trauma centers. So we have almost by default taken away the ability of community hospitals to manage hurt people in any kind of serious way. Those patients go to trauma centers to be assessed. And that's our preference, is to get them to places where if injuries are found out, there's not a delay in care. It turns out that if you divide people up into body regions, one of the other things that comes up is, do we need all the specialty care available at every hospital in the state, at every trauma center in the state? And the answer to that I will tell you is, yeah. That the most commonly injured place is the green thing, which is like extremity things, Dr. Pollack, it's all the orthopedic injuries people get. But the yellow section are head and neck injuries. And there is not a trauma center in the state that sees less than 10% of its patients who the most severely injured part of the person is their head and neck. So we start talking about like the need for neurosurgeons to be available in the lower level trauma centers, or plastic surgeons to be available. All those people we find a need for. The next section, by the way, is face injuries, the red bar's chest, and the yellow section, which is what we think about more often, is actually less than some of the other ones. Yellow is abdominal injuries. So the point of the graphic is, you can see there isn't like a body part that's all the time injured, and we don't need to focus on the composite of the spectrum of injury in people at each trauma center in the state. That is my overview of Maryland's trauma system, and I'm done. Unless you have questions. Radio audience. No, very good.
So hearing no questions for Dr. Delbridge. I want to confess that when you have a collaborative PowerPoint, sometimes slides get dropped out, and I did notice that the charge slide is disappeared. So I think what I'd like to do is visualize that charge slide, and you can also see it from the statute itself. You look at page 2 and 3, it talks about our charge. I think it's important that since we can't show it on the screen, we review that charge beginning at the bottom of page 2, which says the commission shall study the adequacy of trauma center funding across the state for operating capital and workforce cost. Focuses on existing sources of funding, the adequacy of the trauma fund at its inception and today, and additional statutory requirements for trauma centers at the time the fund was established and where they stand today. In addition, we're to look at any statutory changes that can be made affecting the use of the fund, examine changes in staffing, recruitment, compensation, and other factors that cause increased or elevated demand for funds. And I think those concerns were elevated already by most of the people in the rooms. In addition, we're to look at the amount of funding needed to adequately fund trauma centers overall. And consider, here's an important point I said earlier, the funding mechanisms available to adequately fund trauma centers. The assessment on registrations and registration fees is the revenue source today. It has not been changed. There may be room to increase that, but that's a political decision on the part of the administration and the General Assembly. Criteria we're to look at for eligibility, and I think that both applies to a lot of things, including the range of on-calls and standby stipends we would make, the way that uncompensated care claims are are reimbursed. It may not be known to everyone. A few people are aware of this, that the adjudication rules vary between Medicaid, commercial market, and how claims are paid that are uncompensated. And then the commission is to come up with recommendations and findings which focus on changes in staffing, recruitment, compensation, changes that could be made in the approved uses of the fund, the amount of dollars that would be needed, and alternative funding mechanisms that can be established. So it's a pretty ambitious set of charges. We are hoping to have a manageable number of meetings with staff doing work in the interim to make these meetings as effective and productive as possible. So consistent with the uses of the fund over time, I think now is a good time to launch into the history of the fund. I promise to be a little briefer than I envisioned because of the very valuable what we got from commission members at the start. But the fund itself, as noted, has been in existence for 20 years. There have been some changes, but it's important to remember that the trigger for that was the closure of the Washington Hospital, now Emeritus Trauma Center, in the fall of 2002. At that time, they were a level 2 trauma center. They closed and cited the ability to cover on-call and standby stipends as critical to the financial viability of the hospital itself, and therefore, until a solution was found, they closed. The legislature met and considered options for funding, and it was a compromised piece of legislation. In the discussions before the legislature, really 4 funding streams were identified. Although standby and on-call were the triggers that prompted Emeritus to close at that point, there were other needs that shock trauma, Hopkins, Prince George's County Hospital Center at that time cited, and they mostly focused on the inadequacy of Medicaid payment and the inability of physicians treating trauma patients in some instances to obtain any reimbursement. There was no mechanism to cover uncompensated care, although hospitals for those services were protected to some degree through the rate setting system. The legislation that passed was really focused on balancing those out. And I think the history of the fund has been, when we change one thing, we also change another to try to keep in mind, thinking about this from the trauma network framework, that there are different sorts of needs at level 3s, level 2s, level 1, and park, and there are different needs in urban areas versus suburban areas versus urban areas, rural areas of the state. I think we can say that the 2003 Act was successful if we look at, yes, indeed, Emeritus, at that time, Washington County Hospital Center reopened. They reopened instead of as a level 2 trauma center as a level 3, and they continue to operate to this day as a level 3, and continue to see over the last several years, like many of the level 2s and level 3s, significant increases in volume. That was what I'm struck by, and that several of the commissioners noted, that over the last few years, there's been much more of a balancing of trauma volume across the state. I don't know if that's just an incorrect conclusion I made, but it did seem like over the last few years, we've seen volumes going up at Title, we've seen volumes going up at Emeritus, we've seen volumes going up at Bayview, for example. Level 2s, as Dr. Delbridge pointed out, seem to be taking more of the burden, which I think from the standpoint of shared burden, shared cost, is a good thing. I think we'll drill down further into that as we get through these meetings. It was important, but it had limitations in the at the time, and I almost immediately there was movement to make some modifications. We administer the fund, but because it was a balancing act, if you look at the statute and look at the regulations, they are very, very specific for statutory language to spell out the funding mechanism for uncompensated care, the way that on-call could be reimbursed. Everyone knew what they were going to get, which in an area, when you're talking about dividing up funds, everyone would like to have a good idea starting out. But it's turned out, in my mind, to be a disadvantage because there's so little flexibility. Some people have noted, on-call is inadequate. On-call doesn't cover all the specialties. Everything was spelled out in the statute. Really, the only thing that we have any flexibility on is on uncompensated care. We can somewhat raise the reimbursement level for uncompensated care or lower it if fund balances would dictate that. And we have some flexibility on working with our Medicaid colleagues to make some changes in Medicaid reimbursement. But other than that, formulas are pretty rigidly spelled out. Everyone knows what they're getting, but as trauma needs evolve, it's clear that that's not probably the, to use a soccer parlance, the winning formula for success moving forward. We need more flexibility, I'd argue, at the start of this. We can move to the next slide. Now, one of the things that is kind of interesting, and I'll use that term interesting, only is that revenue is pretty stable. I don't know if you have observed this, but I think there's more traffic than there was in 2002, meaning there were more cars. But it seems like from the revenue collected through the MVA that $5, remember $5 every biannual renewal is taken and assigned to the Maryland Trauma Physicians Fund. And on automobile purchase, you would also pay that assessment. Pretty stable over time. We saw a little dip in 2020 because of the pandemic and the deferral of registration and registration renewal fees for a period of time under then Governor Hogan's executive order. It perked back up, but overall, I think everyone conclude pretty flat revenue. I think we might want to ask MVA some additional questions on why it has been stable, because it does seem as though we've seen a bit of a uptick in automobile registration volume, I would suspect. But stable is, of course, which I would reference as you're thinking about what other needs we need to address. We can go to the next slide here, and I think the demands on the fund are very clear that we started out, and again, it was a balancing act. Those trauma centers that largely benefited or reimbursed for uncompensated care those costs were covered. On-call and standby costs, which I actually don't have standby in here. It would probably follow somewhat the on-call trend, which is trending upward. But you'll note that on-call in particular has gone from about $5.5 million in 2008 to close to $9 million today, and that is due to a couple factors. One, there is an embedded inflation factor in the formula we use. And two, now all trauma centers are pretty much at the maximum number of hours they can apply for trauma on-call stipends. During the initial periods, and even as late as 2008, there were a number of trauma centers that reported that they had no on-call for certain specialties. Across the board, and consistent with what people are saying, almost without regard, on-call standby stipends are a fact of life, not just in trauma, but in terms of most other hospital-based services that are part of physician compensation, either explicit or embedded through salaries, is an adjustment for being at the hospital. And I think this is a pretty clear-cut picture of what's happening. A word about uncompensated care, however, and that is that one of the benefits of the ACA and the Medicaid expansion that was included in that legislation was that it made if you are at the hospital and the hospital could qualify you for Medicaid, they were able to do that. I have not delved down into the data extensively, but my suspicion is that many trauma patients are being qualified for Medicaid that up until the passage of the ACA did not qualify. If you look at that data, you can kind of see that what's left is largely perhaps a uninsured population that may not qualify for insurance, undocumented, or individuals, non-citizens that can't qualify for insurance through the exchanges or Medicaid. Although in some cases, they will be able to obtain insurance through commercial insurance plans, depending on their employer. Medicaid payments are relatively low and static, and that's been a question that even as Medicaid expansion has occurred, the amount of funding requests from the Medicaid administration has been relatively low. We don't have a representative, but I think when we get to that discussion, we would want to bring some folks that are experts in Medicaid reimbursement. I think there have been periodic questions about whether MCOs are paying 100% of Medicaid. Recent evidence is that they are, but past evidence has been that they have not always been doing that. If we move to next slide, just a word about on-call payments, very, very specific. And it's clear as I'm listening to you that the 4 specialties that were historically eligible for on-call, we've added a critical care, I believe, in right around 2009, that there are many more specialties that hospitals are saying they're paying on call for. And when I look at the trauma protocols, although some of these specialties don't have to respond in 30 minutes or be at the hospital, they are expected to be available and therefore probably are requesting on-call payments going forward. A couple notes in most of on-call, of course, is going to be paid to the level 3s, to level 2s. It's a blend of on-call payments and standby, meaning for certain specialties, trauma physicians and anesthesiologists, I think they have to be at the hospital if they're in a level 2 facility, whereas in level 3, pretty much everybody can be available on call. The formula that we're using, again, time to rethink that. It was based on a payment methodology that has become dormant, that was used under the Medicare program for non-IPS, inpatient prospective payment system hospitals, that was set up as a reasonable compensation framework for physicians employed or attached to those hospitals. That disappeared in 2014. We can continue to operate this formula because we're applying a inflator from the Medicare economic index, but I think we can rethink that. We do know that there are on-call standby estimates that are done by a variety of organizations, MGMA, Sullivan and Cutter, and a couple others as well. So some thought about refreshing that, although if push came to shove, the Healthcare Commission could make these compensation equivalents work. We can go to the next slide. Slide again, some thoughts. I think I've repeated myself here, so I don't want to cover this. I've covered this pretty extensively. On-call and standby are growing, and clearly we need to reflect and think about whether additional specialties would be eligible beyond the core trauma system specialties. Uncompensated care and Medicaid, again, starting out pretty slow, cautious, if you will. It included trauma surgeons, orthopedic surgeons, neurosurgeons, anesthesiologists, critical care, and a small amount of money for emergency physicians initially, but that's been changed. And they were to be paid on the basis of the Medicare fee schedule, 100% of that fee schedule, which was selected because it was a transparent and available fee schedule to use. Again, changing over time, there was pushback that other trauma providers, not among those 6 core specialties, should be added. The sites of service have also been expanded. But there's been some pushback when other ideas such as adding non-physicians to the fund. They are not currently eligible for funding, as well as certain types of nursing services that are not directly billable to a payer, but do incur significant cost. Kind of tying this all together, uncompensated care funds have payments under the fund have declined owing to the ACA. Clearly we don't benchmark what those fee levels are for trauma care, but commercial payers in the state typically are about 100% of Medicare for E&M services and a bit higher for surgery. So there would be no reason to think for those that are commercially insured that the payments that you get from trauma care in commercial environments are not at least at Medicare levels. And at Medicaid, there is a requirement that for trauma services, they be reimbursed at 100% of Medicare. Go to the next slide. So it's just, again, a thought on where we're seeing uncompensated care, and this kind of goes beyond our work, but to think about, who is left not covered. If we had an insurance expansion, and you can see that we look back over the last 5 years, and this data, we had to put this together, and we did not include patients for which we could not assign a race. So it's not a complete rendering of all uncompensated care payments, but it does show that relative to the population, Hispanics are a larger share of uncompensated care, which might lead me to conclude that we do need to pay attention to who's not eligible for insurance coverage. Not our job, but where are the gaps? And consistent with what Dr. Delbridge and others raised, uncompensated care payments are not always the catastrophic injury. Many of them too, as he indicated, are rule out cases at smaller reimbursement levels. On your right, uncompensated care trauma payments per capita, typically, we could also say that's per episode, because it's rare that a patient would have multiple trauma episodes over a course of a year, but I suppose it could happen. So I consider that those are the costs that are incurred for a trauma incident over the course of that illness. Next slide, please. So just a comparison of revenue. This is just looking at the last 2 years to bring us up to date. A couple things. Revenue did slip a little last year from where it was in 2021, and we don't have a good explanation for that of the fluctuations. Clearly in 2020, it was due to the executive order. Uncompensated care continues to sort of trend downward, although we do see little blips in funding, but compared to the days when it was close to $6 million, it's much less. Medicaid, it's very flat, but on-call is a big driver, and there's been consistent comments from the group here that the scope of on-call payments, both the level and the specialties that are eligible, may be an area for consideration going forward. If we can move to the next slide. Lastly, to kind of kick us off, really the guts of the meeting and the meetings going forward. I think I've heard from everyone, more flexibility is on administration, on the disbursement of funds would be valuable. There's as we think of greater needs, the first thing that comes to mind is increasing the MVA surcharge or assessment. That's never been increased, of course. Legislators and the administration are going to think carefully about whether that type of increase is something, given that we're still coming out of the public health emergency, is something they want to consider. It's my observation that there's not much in the world that costs the same as it did in 2005 when we first got started, but that will be a political decision. Can we increase Medicaid reimbursement, recognizing that trauma patients have higher acuity, more complex, multiple conditions, et cetera. And also, the funding on grants is capped under law 10%. We certainly are building up reserves because we can't spend the fund, that we need to address that. And the possibilities that I think there should be carefully considered. The idea of replacing the funding mechanism for on-call and standby are areas that we think warrant some debate, and expanding eligibility for on-call and standby beyond the specialties that are currently eligible is also a consideration. There has been discussion about how nursing costs associated with trauma, which are usually not directly billable, could be considered. And there's additional audit and oversight responsibilities that could be assigned to NHCC, including delving into what's actually happening with a little more detail in the Medicaid arena. And lastly, there's been some advocacy for really changing the adjudication rules, in particular in Medicaid, which has a requirement that multiple procedures are reimbursed at a descending percentage of the full payment as more of those procedures are performed. The argument is with trauma patients, severely injured trauma patients, it's the rule rather than the exception that you have multiple systems at risk and therefore more complexity. Virtually all of these are going to take statutory changes as we think about this going forward. And so that's something that, how big of a legislative package would the trauma community be able to support broadly and get the legislature to support is something that we have to consider. We're mostly not political animals, but the reality of what can be funded is something that is an issue that we have to consider. I think we're done, and 45 minutes or so.
Question. Was any analysis done on the suggestion here from $5 to $6? Because as you said, there's been a lot of inflation that happened since 2005. So a $1 increase doesn't seem like a lot, but I also know we have to consider the population of Maryland residents, but how much would that add and how much would that help?
So it would add be a 20% increase in fee in revenue. So it'd probably jump from about 12.2 to 15 billion or so, 14.5 million. So it would be some. I mean, at this point, keep in mind that the trauma fund builds surpluses periodically because the funding streams are not adequate to absorb all the revenue that's generated. That needs to be qualified that there are funding needs that are not spelled out in the statute that we can't meet. We articulated them today. More specialties needing on-call, inadequate uncompensated care payment, perhaps, nursing costs, et cetera. But by sweep of hand, we can't make those changes. So
Harry Herrera has. Secretary.
Dr. Herrera Scott.
So yeah, I'm building just off that question, right? we don't want to charge more fees if at the end of the day, it's not going to be enough money. And there's a lot on the table here that you're talking about adding into the trauma fund that already is not enough to support what's in statute today. So that's one. So really understanding what stays in, what comes out. And given the acuity of what you described, we really want to think about what the trauma fund should be paid for based on the acuity. And I heard the testimony by some at the table about why it's all, you have to rule out before you determine the lower acuity stuff. But is there going to be an exercise to say, based on what's in the system today, what does that cost? And if you add or take away any of these other services, what is that cost? And then figure out what needs to move up or down to pay for that. And if there are alternatives to that, because 5 to 6, we could do the math, 20%, what you just said, but it seems arbitrary. And if you raise it and it's not enough, then it's for naught. And then again, does everything belong in the trauma fund versus, adjustments in rate setting and other levers?
Thank you, Dr. Herrera Scott. All very good points. And what I would just put a period on that the trauma fund was viewed as kind of the supplemental, the last stop. Then if it wasn't available through reimbursement to hospitals or payments from insurance, public or private carriers, then the trauma fund would pick that up. That was the original thinking behind.
Right, but we've added a lot to it now, which is why we're having this meeting now. So again, what should the trauma fund be used for? Do we need to go back to that original question? What is the delivery system we have today? What is the delivery system we need? And then how much does it cost for whatever this group or whoever defines what is needed?
To Dr. Herrera Scott's point, while we may
Mark, why don't you say who you? Yeah.
Well, I'm Mark Marcantano again. I'm the Chief Administrative Officer at Johns Hopkins Children's Center. Did anyone hear me? Could you hear me?
Yes.
Okay, perfect. To Dr. Herrera Scott's point, while this list may look oversubscribed, it sure does, I would like to understand better whether we can take advantage of the opportunity to more further recognize the premier status of the pediatric trauma and burn programs and position it, I would say, with the esteemed status of PARC and the shock trauma program. And even if everything can't be funded in the sort of mainstream discussion we're having on this list, if these programs can be established in, I'll say, the state government ecosystem more broadly for the potentiality for things down the road. Because I do think these are very special programs and they deserve esteemed status. Could we consider that?
I think this group can
Consider anything.
Yeah, I think we want to stay within the framework of trauma, but there are externalities in the healthcare system that are affecting trauma, and I think we have to point that out to policymakers. I think we would have disagreements probably on what those externalities are, but they are factors in the trauma performance of the system today.
I have another question online from Mr. Gannon.
Hey, thanks. Thanks. I just wanted to kind of piggyback off what Dr. Scott was saying, and I think just say that I think we need to look at exactly how much increase in funding are we looking to need, or are we going to require? And as she said, is this $1 increase going to be enough? And if not, is there opportunity for us to get creative and look elsewhere for other sources of funding? Just a few things that come to the top of my head is the recent legalization of marijuana or gambling, and all of those things that we've kind of implemented or made legal over the past couple of years that are bringing the state some extra revenue. But I think first and foremost, we need to find out what the increase looks like, what our current costs are, and how do we get to that difference?
And I want to add Trudy Hall, Title Health. I want to add to that, it would be helpful if we really had a true understanding of the costs and the reimbursements and where are we with those gaps for each of the levels in urban and rural. So, I mean, so much has changed even in the last 3 years from the pandemic. More hospitals are having to employ physicians and as well as having gaps in coverage. And then really, what's the delta? And then what's the true amount that we're trying to shore up? And what are our other options to kind of echo, our previous member, what are other options that we have on the table to be able to get that shore up, whether it's from a state or again, other payment systems. So I think, that would be great to know.
Yeah, and just to be clear, in terms of this last slide that we're all staring at, that's not, the palette of things, of proposals. That's what's been considered and deferred or set aside. So don't use this as considerations. Some of them were not adopted because they were too expensive. But they represent philosophical changes in the underlying principles for which the fund was originally established, and it was like based on consensus. Let's not do that at this point. So I don't want to say we're all focusing on this. Some of these, most of these have not, a cost number was never generated, or if it was generated, it probably is of not a significant amount of value because it was in the period before 2010.
This is Ray Fang. And I would just say that when we kind of crafted this idea of this commission, we purposefully worded it so it was not only related to the trauma fund, because the trauma fund has a finite revenue. And it could be that the cost to support a very viable trauma system and trauma centers exceeds what the trauma fund could even support. I would also say that I don't know that there's a real, and I would defer to the history and experience. I don't know that there's a real purpose for the trauma fund to run a huge surplus as a rainy day fund. I don't know, maybe there are examples, but over years we had grown a huge surplus and it was taken away. So I think the trauma fund should get spent to support the centers as much as possible with a reasonable surplus. And there's been a lot of work in the trauma community looking at how much does it cost a hospital to be a trauma center. There's actually an article, Journal Trauma, which I can share with this group later. It said, how much green does it take to be orange? Because the book, the manual that specified the requirements to be a trauma center used to be the orange book. It changes every couple of years and everyone refers it to by the color of the book, the green book, et cetera. The last version of the requirements to be the trauma center was the orange book. So the state of Georgia undertook efforts to say, how much does it cost per hospital? How much green does it take to be orange? And they gave a number, the cost for the trauma program manager, the TMD, the PI nurses, all the on-call costs and all those things. And they tried to come up with a rough guess. And I don't know if their methodology is perfect, but it is at least someone's effort. So perhaps I could share that with the group and we could see the expenses that they looked at and things like that, at least for the state of Georgia.
Consistent with Dr. Bass's admonition to me, it's all, the expertise is here, but I think it would be valuable if you could share that. Dr. Pollack?
Yeah, just a couple of thoughts just to understand, in the past, the creation of a surplus was the result of a lack of flexibility in ways to spend the fund more than anything else. It wasn't because of any desire to create a surplus that subsequently goes away with a BRFA. So that flexibility becomes very important to make sure that we're spending the money wisely. Looking at other states around the country is still valuable. The trauma care system in Maryland is premier, but the trauma funding system in Maryland, the healthcare funding system in Maryland is unique in the country. And it's important to understand that while the average cost of care is measured based on the cost to CMS for delivery of healthcare in the state of Maryland, and the GBR is modulated based on how we perform relative to federal standards. In other states, there is substantial additional funding outside of insurers through state legislatures for trauma care. And how we bench in the state of Maryland to those other states is important as we start to make sure that we're not overburdening GBR for that cost. And that we're actually recognizing what that real cost is to deliver that premier system to the citizens of the state.
I think.
I have
Dr. King?
my question, it's Christian Kane. The question about the surplus and the history regarding the surplus was actually answered by Dr. Pollack. It seems like it was a little bit, the process was let's say it was prohibitive to the folks that were seeking to get those or recoup those funds. And I wonder if there are any other hypotheses that are on the table about why the surplus exists. Have there been any other investigations to why the surplus exists?
The statute is very formulaic and you know, we on call is specified, the funding levels, the funding maximums are specified, the reimbursement levels for uncompensated care and Medicaid are fixed. So based on the formulas, surpluses are going to develop, and you know, we have tried a couple times to get more flexibility. We have not done that, but the trauma community has not been, you know, fully aligned with some of the ideas we've had. So I think Dr. Pollack outlined it very well. I'll just put a point on that, that the goal, if nothing else, is to get more flexibility in the distribution of funds, so that if one funding stream, the need drops, a surplus does not start to automatically accrue. Dr. Hall.
I was gonna add more, but I do want to also add that, you know, some of our populations are changing, especially in the lateral parts and southern parts of the state. I just found out as a 60% increase in Haitian Creole population on the Eastern Shore, and 29% of Hispanic, and a 22% of elderly over 65. So I think a lot of times these formulas sometimes doesn't really account for some of the lag in the increased burst in certain populations. And I know Cap Region has the same as well. So I just want to make sure whatever we figure out, and I do like the thought of we're going to look at other states, because a lot of other states have thought of creative ways of being able to subsidize this, but increase physician costs, increase physician reimbursement, decrease in physician reimbursement, and the increase in the uncompensated or undocumented populations, in certain parts of the state, especially rural.
Other comments? So I was going to ask Kate, not to put her on the spot, but you know, but you know, who will be in terms of, you know, that my sense is that there's not a specific carve out for trauma, although it's important to emphasize that standby, which is deemed a Part A, Medicare Part A cost, obviously. In Maryland, we're talking about more than Medicare when we talk about Part A costs. That is rolled into rates today. At the time that the legislation was passed, the then leadership of HSCRC said, standby, it would have been much easier and much easier today if standby was in hospital rates. It's my understanding that that would not be, it's not considered a Part A rate. But my question is, has CMS showed any more flexibility to adding Part B cost using that mnemonic into hospital rates?
I have not been part of those discussions, but I can certainly bring that back to the team that works with them regularly.
I mean, to the, Dr. Pollack's point, you know, adding something like on call would put pressure on GBR. How much, you know, we'd have to ask the technicians to tell us, but you know, the total cost of care by its very nature, if it's not directly impacting Part B cost, it is affecting them indirectly. And I think the state is in a better position to advocate, for that inclusion than they were in 2003, when it was very foreign to lead those two together.
Yeah, I think the point I was trying to get at is that the rate, adding pieces of the cost to the rate system is a zero sum game. Right? It's gonna come out of somewhere else in the rate system, in the hospitals. We can't just increase the total rate structure without risking the tests of the model. And in other states, there is substantial state investment, state level investment outside of their rate structure. Rate structures are obviously substantially different, but there's substantial other investment, which takes that pressure off.
So just to keep the conversation going, as I'm processing what you're all saying, so a few people have made mention of the cost, the green to be orange, the things that trauma centers have to do that are not, we would think of as reimbursable. They're not patient care centric things necessarily. There's have a program manager, there's have trauma registrars, there are infrastructural costs that go into being a trauma center that other hospitals who aren't trauma centers don't experience. Is there value in, so that we don't get the cart before the horse, is there value in inventorying what some of those things would be, what additional costs a trauma center incurs, and then begin to figure out like, what are the potential sources to offset that expense to a hospital? I mean, I'm not discounting the possibility that in my head, that the trauma fund paying for physicians to be on call is necessarily the right way to spend all that fund, or maybe a physician who's on call for the trauma center isn't necessarily just on call for trauma. He or she is on call for things that aren't injury, right? So the entire, I don't mean to subtract it, I don't mean to make it a zero sum thing, but it might be that we consider what the costs are to be a trauma center, and what proportion of costs of individual people's efforts relate to being a trauma center versus a hospital, that we can begin to assign where we imagine the offset for those costs might come from, whether it's a physician fund or additional resources that we conjure up, or something that pays for general care anyway. Not helpful, you agree with that?
Absolutely.
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 Absolutely, absolutely. Because we haven't even talked about APPs.
Yeah.
I mean, a lot of us are, having to have APPs to help to supplement to work. And a lot of times they can't bill as well as the physician bill, and, first of that. Yes.
Assign somebody to do that.
So we, from the very outset, we've kind of fragmented what our sense of cost were, that in level twos and level threes and level two trauma centers, most of the additional cost is labor. Nursing cost, trauma, the trauma director, the standby and on call that might be required to keep those specialties on the call. With level ones in Park, because of the physical plan that is in place, that may not necessarily be completely true, but I think refreshing all of that information would be helpful. But I've typically looked upon this as a problem. How do we finance for bulk of the trauma centers that are additional labor costs related to trauma? But can I put a dollar figure on it? Costs $2 million to be a trauma center, $10 million in terms of additional operating costs. We'd have to start over.
What's the market?
It's like I have the number. Pretty sure.
So,
There's that organization, of course, but I think we
Yeah.
could certainly, segregate out what we believe for having a trauma program.
I also don't think that there would be a center in the state that would not support submitting that number to get to a better utilization of the funds that exists as it is right now. I certainly would imagine that our CFO would be among the first to turn in some stuff.
Mike will turn it in. We can get the level threes.
This is Ray Kane. I will share that paper when I get back to the office. The other comment I would make is, it is my understanding that most hospitals each year do send a summary of the cost to be a trauma center. And then that gets evaluated as part of the rate structure. But I think, and again, I don't 100% understand medical reimbursement in Maryland, but I think I understand it more than most of my trauma colleagues. I think when things get put into the rate, and Dr. Pollock, you probably understand, it's a little bit hidden, the benefit of it that the state is given to you. And so it could be that the state actually supports us very well as trauma centers, and we have no idea because it's hidden in the rate. You laugh a little bit, but I don't know.
It is in the rate. Yeah, but the problem is that as we add more things to the rate structure,
Yeah,
it doesn't increase the total rate.
I understand.
Right,
Right.
so
It's
so what we need is to increase the total amount that's in, and the idea of driving the solution to this problem to the rate structure is not going to work. We're going to have to figure out additional sources of funding.
Or the rate structure plus, so if it can be, but not really thought of the total cost of care. The other thing too is, there's a difference between level 1, level 2, and level 3, they're GME. So again, there's other areas where there's funding, but I know level 2, how much GME you have, and level 3 is low GME. So we're not able to maybe get funds that may be other higher level with more faculty and the ability to offset some costs. We don't have that. Does that make sense?
So other kind of starting points where staff should do some additional work. I think we will ponder that, and I've recorded every system's commitment to provide, the financial accounting that would be warranted for us to make that on a pretty short turnaround. Our next meeting is in about a month. Other ideas that we would want to consider. I mean, I think one of the areas that this is a narrow area, but activation fees. There is Kaiser Health News had published something earlier this year about HCA, not a system that obviously operates in Maryland, but they had concluded that they wanted to have as many hospitals as they possibly could owned by HCA as trauma centers, because they did the arithmetic on activation fees and concluded that that's a lucrative revenue source that could be used hopefully appropriately. But one of the ideas is is there some state relief for activation fees? Any thoughts on that?
Can you explain what what do you mean by activation fees?
So when a trauma, yeah, go ahead.
So in many states, if a patient presents and they meet trauma criteria and the trauma team presents and is ready to care for them, there's an automatic charge to insurance. And depending on the state, it may range from $50,000 to $50,000. So in places where it's excessive, a lot of private players will go in and try to be trauma centers because it is profitable. So there's a lot of, fighting, because you may go and sprain your ankle and EMS says they don't feel a pulse, and you just have an ankle sprain and they just didn't feel a pulse, and now you have a $50,000 charge for a sprained ankle that's upfront before any evaluation. So I'm not saying that that's the answer, but that is something to help offset the cost of everyone being available in their states.
But that's a charge to insurance.
Usually charge to insurance.
So once again, I'd say that in Maryland, that's inside the rate structure. That will not add dollars to the system. That will just move dollars around inside the system.
I wasn't proposing that. I mean, it is a charge. It happens today. Our very crude estimates. I think the story that I now share this with you. It's not a research generated. It's the news. It probably needs to be qualified. I'll give you that. But they talked about average activation fees were like $10,000, and HCA was charging $25,000. I'm not suggesting what is happening in Maryland now. We can't get a really good figure on what that is, but it looks like it's $4,000 or $5,000. Not like what they're talking about in that area, but in terms of subsidies, rather than the payers absorbing that, is there a fund, certainly for uncompensated care? We might, there's no activation fee payment by anyone for uncompensated care. I don't know about Medicaid, but that's a cost that could be funded. We don't want to induce any demand for activation of the trauma team, however. You'd have to think about that carefully.
And we had spoken at TraumaNet about trying to create defined trauma activation criteria, so you could, this was just an idea, and it takes a lot more to be worked at. I also want to bring up, I Googled the article about how much green does it take to be orange, and just from the conclusions, they said the average readiness cost for a level 1 trauma center is $10 million. For a level 2 trauma center, it's $5 million.
Those are readiness costs. So for building up a program.
Or having on-call, OR availability, all those things. Just as ballpark.
Yeah, and just to remind everyone, EMS and transport and those costs are they're charged separately to patients for their insurances, so they do have to pay transport costs.
And can I ask, as you're educating us, and so makes clear sense that as we activate more intensive resources, that's worthy of consideration for some reimbursement, whether the current flow is abused or not in other areas. But I'm also thinking so many of us are uber resourceful, and as was pointed out, these talented people are doing other things. So there's an opportunity cost, right? When I get activated, we're not doing something else. And notwithstanding the limitations of GPR, as I understand it, there's still charge authority against, right? Have to, keep doing your book of business plus to activate that charge authority, all of the things being equal. So I just want to make sure, I think this is an important concept we should push forward and then work out the details. And I do think it's going to have to be ideally outside of GPR. Should be a strong voice around this.
So Dr. Hall, you're the voice of the level 3s. This meeting. Can you characterize, not just for title, but for what are the specific challenges you see based on the framework that we're looking at today?
And it's interesting, I spoke yesterday to the CFO for Emeritus, so and when he was telling me all of his challenges, it was ditto, 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 ditto. The difficulty in recruitment of the physicians, the rural areas, we have to pay higher recruitment fees for the physicians. We also have more shortages, so we're paying more locum fees, which is 3 to 4 times on the dollar to meet the requirements. We're also having vendor entities that are pulling out of vendor care that's now requiring our hospital system to employ. Anesthesia is a good example of that. With the anesthesia shortages now, anesthesia vendor providers are pulling out. They're not making money. So now hospitals are having to employ, they're having the same problem. And then they're having community practices fold and they're no longer able to provide care. So they're having to look at possibly employing some even more community practices. So I think both the rural side, at least Emeritus and Tidal Health, just for us to maintain care, we've had to go to a more of an employed model and have had difficulties with recruitment and retention and higher physician costs.
So all of those challenges as a given, but wouldn't on-call costs go down if you have only employed physicians?
Depends, because then you're paying it in salaries. So you're paying, so the reality is that's where I'm really saying the cost is the cost of the cost. You're paying the physician. This is pushing it to an on-call or subsidy. So you still are having to subsidize a physician, but not through a vendor contract. You're now having that through employment. So we still have, independent community providers that do call. So we're still having to pay for it. But the model and the costs is not covered through rates. Still cost on the hospital that we're having to do these additional services. So I think that's why going through this exercise is going to be helpful, because then it would kind of give a little bit more transparency into what we're paying. That makes sense. Yeah.
Mr. Gannon, you're the representative of level twos, although
My middle's the.
we have another representative here, but let's start with representative from Sinai, and then we'll talk with Cap Region.
Yeah, so I think some of the challenges, just to go off of what was previously being said are some of the very same things. We have as a level 2 more surgical specialties that we need to outsource or contract in. And I can tell you those have gotten increasingly expensive, especially over, say, the last 6 or 7 years here. We're not too different in that we do need to use locums, especially for some of our specialty surgical services to make sure that we have the appropriate staff in-house 24/7. And yeah, it's a lot of the same struggles.
Dr. Kane.
Yeah, I would concur with that as well. I'd say, I think the context that I think is going to be very important for us is to realize that level 1 is not the same as another level 1 and level 2. The level 2s can vary as well. I think in particular, the center at Capital Region where we have penetrating trauma, for example, that's overrepresented up to upwards of 2 times a national average, right? So a lot of the pathologies that we are actually treating require uber specialized care, where multiple times, and it actually is a very beautiful thing to see, but and in your mind, if you are actually calculating the cost of the presence of the people that are in the room, it can be very expensive. And so having and maintaining those folks on standby or on call is an additional cost, and finding people when, as a result of the pandemic, should I say, many of the specialists have looked elsewhere outside of our systems to look for jobs. And so who are we going to have to pay to be available and on the schedule? And are we going out and getting locums, for example? Are we having to increase the amount of money that we offer to community practitioners in order to bring them into our systems as well? So ditto to everything. And also, I think it depends on the mixture of folks that you're actually taking care of.
So Ms. Williams, you're the level 1.
I think many of the same issues that the folks have already said in the room. The only thing that I would add to that is ease and flexibility of the process, being able to apply for the compensated care funds, one that is less taxing on the physicians. And then the other thing, really just, honing in on expanding different disciplines that are eligible for this fund, in recognition of what everyone has said here today. It is not just the physicians, it is injury preventions, trauma coordinators, it is registrars, it's all of these folks. So the $10 million number, I'm not surprised by that. In fact, it likely could be more. And I think there has to be some expansion in those definitions to give recognition and credit for the work and the support that's there. And to Dr. Hall's point about recruitment for physicians, being market competitive is a big piece of that. And if you're going to bring in physicians and then even if it's part of their salary, but expect that there's going to be a significant amount of call, you're going to pay for that. You're going to pay a premium for it.
And when you're talking about call from Hopkins, are you talking about call embedded in salaried physicians or community-based physicians? I'm not really familiar with their city community-based physicians at Hopkins. I didn't think so. So it's embedded in salary.
Separate on call rates.
I mean, part
Separate on call rates.
Rates.
Yeah, and we're looking at 75 over 95 percentile of rates. That's what they're wanting.
Dr. Pollack.
Well, just the $10 million for a level 1 trauma center, the requirements, as you know, of the park in the state of Maryland exceed the level 1 requirements. And 10 million, I would guess, sitting here is an underestimate of what we invest each year in the standby piece. The ability to run a specialized trauma operating room is not, that there is no specialized trauma operating room that I'm aware of at that level anywhere else in the country. And the challenges with maintaining anesthesia and nursing staff are unique in that model. You have 6 rooms that run, or 9 rooms supposed to run during the week, barely able to run 6 now because of staffing. But you also have weekends running at about 4. So 4 of roughly half of your total operating rooms are running the weekend. Why that's important is because to find nursing who are willing to work that many weekends in that base is very difficult. The cost of supplementing that becomes much higher than you would see in other models. So that additional standby cost of having that resource to the state is substantial. The cost of anesthesia for the exact same scenario is substantial. And just because of the lifestyle issues that it creates, there is at some level, you have to be able to pay for that. And as I said before, it's important that we're not going to be able to look to the rate system to offset that cost, given the other challenges of the rate system relative to the test of the contract with the federal government. The additional, the same argument can be made of a trauma resuscitation unit, right? Which is not part of an emergency department, it's a separate trauma resuscitation unit, and the costs of that staff. All of these challenges have been present for a long time, but the degree to which they have been accelerated, magnified by the labor crisis of the past several years is can't be understated. So the need to figure out that differential cost support structure is very real. And then everything else that everybody else just already laid on.
And the other thing that I found pretty ironic is in looking at one of the graphs that you showed, the revenue stream over the last several years has remained relatively flat. That is the only thing I think that has remained relatively flat, because our costs certainly have not.
But given the structure we have, we can't even spend that revenue.
Right.
Yeah, or given the restrictions.
Yeah.
Medication, we haven't even talked about medication, supplies, hardware.
I mean, if you go back to that graphic, right again, that 12 million is flat. That was the revenues, right? Everything we're talking about would eat that up, that 12 million,
Yeah.
like in a bite. So I think we're going to need to look to outside solutions or propose. So we're just making proposals.
So do you want to go to the next slide? I think that one of the feedback items for sure is a financial summary document. Trauma centers that are in the room thought that could be provided. I think we want a couple people to volunteer to work with staff to put that together. I mean, we're not talking about a Medicare cost report here. We're talking about something relatively pointed and specific, yet enough information for us to draw conclusions. And for not sure that everyone can speak for their institution, but the consensus here was that most trauma centers would be willing to put that together as long as it's not overwhelming. Okay. So I think that's the assignment is, are there any volunteers that would want to work with, give us some ideas in terms of a financial template that would be appropriate for all trauma centers?
I would certainly.
Anyone else?
I can help.
Those
Identify some
3
people.
separate groups or that one group and do all of this.
So I think that we're adding a 4th item for this group that between now and the next meeting, probably between now and the end of August, we would like to have a a financial reporting sheet. I think it's probably not likely that we're gonna have all this data back by the middle of September, that we'll probably have to wait until a bit later, but once we get down to see what we're actually asking for, we can make some assessment of how long it might take. Recognizing that no one's sitting around controlling their fingers these days. But in terms of the next meeting, what we had sketched out, and we have a more, extensive work plan, but we haven't shared that yet with you, because this is kind of an organic group of facilities that we want to be sure we're capturing your input as well. But what we had talked about, we think is still relevant, given, Dr. Fang's comments are, what are the different parallels and differences between the US and Maryland. We've touched on that, but a more systematic approach. Dr. Pollack's statements notwithstanding, is there wiggle room in the GBR at all? I think we would like HSCRC to sharpen their pencils on that one and talk about that. And I think what we would do with the third item is, based on input today, try to synthesize based on what you all said, what are some of the unmet needs consistent with some of the broader priorities that Secretary Herrera Scott laid out at the very outset about aligning it with what we're trying to do with the trauma system. We certainly recognize across our entire palette of responsibilities that equity is something that we need to pay attention to across the healthcare system. We need to think about that as it relates to trauma care as well. Entertaining other ideas that need to be laid out for the next meeting. I think that's a pretty ambitious agenda. Dr. Kane?
Yeah, I was just gonna suggest that maybe to make our goal a little bit more reachable, and since there are representatives of parks level 1s up through 3s here, that maybe we say at least we would try to get representation or financial representation from the organizations that are represented here, to give us some idea of what the cost of the operational cost of the trauma center might be. So just saying, if the commitment can be, instead of a broad net of all of the centers here, at least getting that information from the centers that are represented here at the table.
Yeah, I think, I think that one of the challenges, going back to the representation, we were contacted by all of the level 3s that wanted to serve. I think if we do anything, we would not want to make it exclusive to just the folks in the room. I think we should.
Oh, yeah, I've reached out to them and have a follow-up meeting with them after this. So I'm making sure I'm very inclusive of all the level 3s and getting them back information. So I'll try to get all the level 3s, at a minimum 2 of us to send information back. So I'm trying to be very proactive about that.
And if you can agree to be kind of the spokes, you and Dr. Delbridge on the trade-offs between Maryland and the US, that would be helpful. Any other points we've missed or comments that you want to share first in the room? How about those that are listening on the line? Very patiently and quietly, I might add, given usual MHCC remote hybrid meetings, there's yelling and screaming, and sometimes we actually pick up a few dogs. So I want to commend you for keeping your silence. Hopefully we kept your attention. But any comments in the room? On the phone.
Jim Gann had a comment.
Jim?
You just want to state your comment?
In the chat.
Yeah, it just kind of dawned on me that I think we have all also suffered from increased length of stays and difficulty discharging patients, especially over the last several years. And this has caused just extraordinary amount of volume in hospitals that's really putting a pretty significant financial strain. These patients often, they're ready for discharge, not having any medical treatment for 5, 6, 7, up to a week, if not longer, waiting for placement. So that's just, I think, another financial struggle that I wanted to mention, that we all share. And, placement for trauma patients can even be more difficult than some of the medical patients that the rest of the hospital takes care of.
So we should be able to include the $9 of patient care into some of our cost analysis report.
Right.
Yeah.
There's an opportunity where the HSCRC might be able to help. So if there's a way for those denied dollars not to be charged against the GBR, associated with delays in transfers to SNF, that's a real way without increasing the total GBR to help hospitals mitigate that challenge.
Understood. All right.
Thank you all.
Thank you all for last comments. Yield to Dr.
Thank you all. I'm done. We will also distribute our version of an inventory of what it non-compensatable, non-reimbursable expenses that we understand trauma centers have to incur to be a trauma center. Various personnel and portions of people that do stuff. So that you can make sure you're talking about the costs. Okay.
With that, a couple last points that we have another on the distribution of the $9.5 million that was a budget item in 2023. We are inviting all trauma centers to comment on, to come to a meeting on the 29th of August. Hoping that we can resolve this with this 9.5 million within one meeting or at most two, because this is not going to solve anyone's problems, even if one facility got it all, which is not going to happen. But there are formulas that we've already started to experiment with. Think about that, take both into account the volume, the significance of your trauma population, as well as the underlying stress that the institution may encounter. But I think the message today I heard is that everyone is facing some challenge. So thank you very much for your attention.
Hey, Ben, it's Laura. Before you go, will you be sending out the slides?
Yes, we will send them out to all of those that have not received them. Try to not duplicate, send out repeat slides. The meeting summary and the recording should be up on the commission website. The recording early next week. The summary a little later this time. And those who volunteered, I think I have Dr. Pollack's contact and Dr. Fang and Ms. Williams.
Need another volunteer?
It's fine to be, if you want to be part of that. I mean, I think you call it a subgroup too, but I don't plan on meetings over the next month. I'd like to do it all in one meeting and the staff then run with it. Okay.
Send the data.
Add my name to it.
Thank you very much.
Thank you. Thank you. Mr.